Hello, and welcome to today's program on idiopathic neuropathy, hosted by the Foundation for Peripheral Neuropathy. Today's webinar will cover the specific cause of neuropathy, including its definition and diagnosis. You will learn how to tell if it's progressive and what to do if your neuropathy symptoms keep getting worse. We'll also talk about various tests you can consider undergoing, as well as reviewing some off-label, alternative, and experimental therapies. My name is Lindsay Colbert, and I am the Executive Director at the Foundation for Peripheral Neuropathy. It's hard to believe that I've been leading this organization for over 6 years, and this is the first time we've held an educational session specifically geared towards idiopathic neuropathy. I'm sure many of you share those same sentiments, so let's go ahead and get started. Before we do, just a few logistical matters. Yes, this webinar is being recorded and will be permanently housed on the Foundation for Peripheral Neuropathy's website, along with the slide deck that is being used during this presentation. A copy of the recording will also be emailed out to everyone who registered for this program within the next 24 hours, so check your email and our website for these materials. A question and answer session will be offered at the end of the presentation. For those participants who are joining us live today, you will be invited to submit your questions through the questions box on the dashboard of this platform. Please try to keep all questions general in nature and specific to this topic, and note that we will not be answering any personalized medical questions during this program. Lastly, if you are having any audio problems during the session, please consider dialing in through your phone. That number can be found in your registration email that you accessed recently through getting this link. Now, I'm pleased to introduce the program's guest speaker today, Dr. Norman Latov. Dr. Latov is a professor of neurology at Weill Cornell Medicine and the New York Presbyterian Hospital, where he also served as director of the Peripheral Neuropathy Research and Clinical Center, and prior to that at the College of Physicians and Surgeons of Columbia University. His laboratory is credited with the discovery of anti-MAG and GM1 ganglioside antibodies in neuropathy and for developing diagnostic tests for these antibodies in clinical practice. Dr. Latov also served as founding board member and clinical and research director of the Neuropathy Association that was subsequently absorbed by us into the Foundation for Peripheral Neuropathy, and was partner in Therapath LLC, a neuromuscular pathology laboratory that was acquired by Inform Diagnostics. He has over 200 publications, including research papers, reviews, editorials, chapters, and books, and is the author of Explaining Neuropathy, Symptoms, Diagnosis, and Treatment, or When the Pain Won't Stop, for people with neuropathy and their family and friends. Now, without further ado, Dr. Latov, I'm pleased to pass the microphone over to you.
Okay. Hi, thank you for inviting me to speak at this webinar. I'll be talking about idiopathic neuropathy, which is not commonly talked about because there isn't that much known about it. First slide. So this cartoon shows, at least attempts to show a physician explaining to the patient that they don't know what they have. You have a serious illness of undisclosed nature. You could see it's both, there's consternation both on the part of the physician and the patient. There isn't much information about it, and there are no guidelines as what to do about it. Next slide. Next slide, please. Yes. So where does the term come from? Well, medically, we use it to refer to any condition or disease for which the cause is unknown. It's not an entirely appropriate term. Idiopathic actually translates to a disease of its own, which is not entirely accurate because it's not unique to that patient. We just don't know what it is. A more appropriate term would be cryptogenic, which means hidden or unknown. It could be cryptogenic because the cause is not known or just hasn't been identified as yet. From a patient's perspective, however, it's best described by one of my patients who calls it a blend word between idiotic and pathetic. It helps to talk about it, but doesn't say what it is. Next slide. So this slide shows how we derive a diagnosis of idiopathic neuropathy. In the scheme of things, EMG and nerve conduction studies are particularly important. Just to go through this table, patient with suspected neuropathy undergoes electrodiagnostic studies. The neuropathy is then either classified as axonal or demyelinating, or if normal, they undergo a skin biopsy, and if it shows neuropathy, it's classified under small fiber axonal neuropathy. All small fiber neuropathies are axonal. Now, there are certain conditions which cause demyelinating neuropathy and certain conditions which cause axonal neuropathy. We test for these, and then if a condition is identified as treated or cause is identified, we treat the cause. If no cause is identified, if the neuropathy is axonal, it's considered idiopathic, which means no treatment is available. If the blood tests are all normal and it's demyelinating, it's then classified as CIDP, which is diagnosed based on the pattern of abnormalities in the electrodiagnostic studies, and treatments are available. So again, if the EMG is not done carefully or in sufficient detail, they might miss demyelination, in which case it's diagnosed as axonal and therefore idiopathic. If it's diagnosed as demyelinating, there is treatment available. So it's important that the EMG be done thoroughly. At least 2 limbs are studied and at least 2 nerves in each limb. So moving on to the next slide. Now, regarding the specific causes of demyelinating neuropathy, these include Guillain-Barré syndrome or typical acute inflammatory demyelinating polyneuropathy, CIDP or chronic inflammatory demyelinating neuropathy, multifocal motor neuropathy, MAG neuropathy, or POEMS syndrome. So it's a limited differential. Also, demyelinating neuropathies could be caused by genetic mutations or hereditary conditions, and sometimes could be drug-induced, such as amiodarone or vincristine. Axonal neuropathies, however, can have many more causes. They could be endocrine or metabolic, such as diabetes, thyroid disease, kidney failure, infectious, such as Lyme disease, hepatitis C, or HIV, autoimmune, such as axonal Guillain-Barré syndrome, Sjogren's syndrome, vasculitis, celiac disease, sarcoid, among others. They could be paraneoplastic, associated with lung cancer or lymphoma, myeloma, or IgA monochromatopathy. There are nutritional causes, most commonly alcohol or B12 or B1 deficiency, or B6 deficiency or toxicity. They could be toxic, such as from lead or mercury, from seafood, drug-induced or hereditary. And if all these are negative, then it's classified as idiopathic. Next slide. Now, if you're diagnosed as having idiopathic neuropathy and you're not sure, you're uncertain about diagnosis, what else can it be? Well, an important distinction is whether the neuropathy or the symptoms are stable or progressive or worsening. If the symptoms are stable, it could mean that you have residual nerve damage from a past illness or insult. These can include Guillain-Barré syndrome, CIDP, which is in remission, treated Lyme disease, acute viral disease from which they recovered, toxin-induced, or other inflammatory conditions. These conditions can cause nerve damage. After the acute insult, the nerves may heal to some extent, but often not completely, and people are left with symptoms which could be fluctuating, and sometimes believe they have an ongoing disease, but it's really only leftover damage. There's no active disease that's ongoing. This happened sometimes in Lyme disease, where people have Lyme disease and have continuing symptoms from the neuropathy, such as tingling or weakness or fatigue, and they think they have diseases still active. They can be treated with antibiotics for months, which doesn't seem to make a difference. And again, the way you could tell whether it's active or whether it's a prior disease is by whether if the disease, the condition is worsening or progressing. If not, then it's probably leftover symptoms. This is actually very common in small fiber neuropathy, which is often self-limiting. Patients have acute onset or subacute onset, and then they're left with sensory symptoms. But the disease doesn't progress to large fiber neuropathy. If the disease is progressive, however, and you're classified as idiopathic, it might be that there's a recognized underlying cause which was missed, either because it wasn't tested for, or because it's not sufficiently progressed to be diagnosed. There could be as yet unidentified genetic mutations. Some conditions can only affect nerves. It can only be diagnosed by biopsy. These can include non-systemic vasculitis or Sarcoid. Both of these usually affect other organs, and they can be recognized by other tests. But at times they only affect the peripheral nerves and can only be diagnosed by biopsy. Sometimes CIDP, which is diagnosed by electrophysiologic criteria, may be below the threshold of diagnosis and not meet electrodiagnostic criteria for demyelinating neuropathy and classified as axonal. But if the disease progresses, it then could be identified. Also, amyloidosis, which is associated with monoclonal gammopathies or lymphoproliferative disorders, which are usually diagnosed by blood tests. The abnormal proteins could be too small to be detected, and the disease only identified by nerve biopsy. Now, having said that, it's important to be able to tell if the neuropathy is worsening. Next slide, please. So fluctuating symptoms, those that come and go, most often indicate a stable underlying disease, and the fluctuations are due to environmental factors or internal factors such as hormones, food intake, etc. The environment can affect the symptoms. For example, increased tissue pressure, which occurs if there's a low barometric pressure, depending on weather, can cause more pressure on the nerves and more symptoms. And that is the case often, for example, in people with rheumatoid arthritis, where they feel worse before a storm because of lower barometric pressure. Neuropathy symptoms can respond to the same types of fluctuations. In general, measuring motor functions is a more reliable way of evaluating for progression than sensory symptoms. They're more consistent, easier to measure, and more reliable. Sensory symptoms such as numbness or tingling or pain are less consistent. Pain is more variable. You can have more pain either because the neuropathy is getting worse or because the neuropathy is getting better and the nerves are more sensitive. Sometimes, for example, in early diabetes, the neuropathy can be very painful. If it progresses, it becomes more severe with more tissue damage. Patients feel numbness instead of pain. They think they're getting better because they're more comfortable, but it's only because they're no longer able to feel pain. However, keep in mind, if you suspect progression, that has to be confirmed by the examination in electrodiagnostic studies. Sometimes there's other things going on in the body which can cause you to feel worse. It doesn't have to be the neuropathy. So you monitor progression. If you suspect that there's ongoing progression, then you need to have repeat examination and EMG studies. Now, how to measure motor functions at home? First, a useful way of doing is using a handheld dynamometer to measure grip strength. Could you go to the next slide, please? Yeah, so this shows a picture of a dynamometer. Use one with a bulb. You can get that on Amazon or other websites. Gripping the bulb measures strength in the palm and fingers, where there's other dynamometers only measure finger strength. So this is the preferred way to do it. You squeeze as hard as you can, 3 or 4 times, take an average. You can repeat that a couple of times a week, log the numbers, and over time, you'll see if there's a change. Everybody has good and bad days, and the results numbers can fluctuate day to day, but the fluctuations will be within a range. If the range starts getting better or stronger, it means you're getting better. If the range starts sloping downwards, it means you're probably getting weaker. Could you go to the previous slide, please? Okay. So also another way is measure strength is measuring leg strength. So the most sensitive functions are those that you could do with some difficulty. If you could do them easily and you get worse, you might still be able to do it. If you can't do it, you might be getting better or worse, and you won't know if there's a difference. So finding something that's difficult to do would be the most useful measure of whether there's progression. For example, depending on specific symptoms or signs, walking on the heels of toes could be difficult and could be monitored. Getting up from a chair without, so walking on the heels of toes measures the distal muscles in your legs and your feet. Getting up from a chair or from a kneeling position measures proximal muscles in your legs. This is without using your arms. Walking up and down stairs, walking upstairs measures strength in the proximal leg muscles, downstairs in the distal leg muscles. You can actually tell by touching your muscles as you do these and see which ones are tightening. If you could still run, you could see whether that's getting easier or more difficult. So all these could be used to monitor change. Walking speed is also very useful. Walking is really a composite of strength, balance, how wide apart you keep your feet, stride length, how long you keep your leg above ground as you're walking. So this is a composite of all these functions which could be affected by neuropathy. So typically people can measure about 25 feet somewhere indoors flat. Walk it as fast as you can and time yourself. Repeat 3 or 4 times, take an average, keep a log, do it once or twice a week. And there too, you should be, could be fluctuations day to day, but the results should be within a range, and you can see whether over time the range improves or deteriorates. Next slide, please. Next one. What to do if the neuropathy is progressive? Well, first it's important to repeat testing. Repeat the neurological exam and also EMG nerve conduction studies. These might reveal changes indicative of CIDP, which is a treatable cause that were previously undetected. Also, previously borderline abnormalities might become more obvious. If these, however, are unchanged, you might have something else going on. For example, sometimes people with neuropathy come in and they're weaker, and turns out it's not because of the neuropathy, but because they have another conditions affecting the spinal cord, such as a disc disease or blood clot or tumor, and they're weaker because of this other condition, not because of the neuropathy. Too often, patients are evaluated by their internist or family physician. They're diagnosed with neuropathy. They're sent to a specialist. They do electrodiagnostic studies, do some blood tests. They diagnose idiopathic neuropathy, and they're sent back to their referring physician. And they're not evaluated again, even if the neuropathy or symptoms get worse. The assumption is that they have the same thing as originally thought, and there's no reason for reevaluation. But if you're getting worse, ideally you should be reevaluated again, because something that wasn't identified earlier might show itself on EMG or blood tests. Genetic testing might reveal an underlying mutation, even if other families members are not obviously affected. You could be the first one in your family, or it could be very mild, or people may not want to admit they have neuropathy. Especially men, they usually tend to dismiss any illness. Also, if the neuropathy progresses, the EMG studies still don't reveal a cause, the blood tests don't show anything, then in about 20% of the cases, a nerve and muscle biopsy can reveal a treatable cause, as mentioned earlier. It might reveal a non-systemic vasculitis or amyloidosis or sarcoid, which again usually shows, sarcoid often shows up in the lung. Vasculitis can cause skin and other organs to be damaged. Amyloidosis can affect the heart, liver, and other organs. And in most cases, these conditions could be detected by a blood test, but sometimes if they only affect the peripheral nerves, you have to have a biopsy for diagnosis. This is particularly the case in non-systemic vasculitis, where only the blood vessels in the nerves are affected. Biopsy can also reveal atypical CIDP. CIDP, again, usually diagnosed by EMG nerve conduction studies, but sometimes these are indecisive, and a nerve biopsy might show the cause. The nerve biopsy needs to be done at specialized referral centers for two reasons. One, if the surgery is not done well, patients could be left with chronic pain because trauma to the nerve. So you need to have an experienced surgeon. And two, you need specialized pathological skills to evaluate the nerves properly. And these are not available at all medical centers, only specialized medical centers, or at least a biopsy needs to be sent to those specialized centers where they could do the pathology. It's better to go to one of these centers because sometimes the nerve has to be processed immediately to look at certain changes. Next slide. So this shows basically electron micrograph picture of a peripheral nerve. You could see the myelin sheaths and as dark circles. Some of these circles pointed out by arrows, the myelin sheaths are thin and indicating that there is demyelination. The axons are preserved, the myelin sheaths are gone. This could occur in CIDP, but also in other conditions, and the demyelination could be secondary to axonal damage. Next slide. but there's something called Tease fibers. These are individual fibers which are teased and stained. As you could see, myelin is denoted by the dark staining with arrows pointing at nodes or spaces between the areas of myelination. And then you could see long areas which are denuded. There's no myelin sheath. And these occur in sort of skip lesion type fashion throughout the nerves in CIDP. So nerve biopsy can identify the presence of CIDP or confirm it when the EMG studies don't show that, or if the EMG studies are indeterminate. Now, again, we don't do nerve biopsies lightly because there is a certain risk for infection or lingering pain. So we only do that if the neuropathy is progressive and no other cause can be identified, which is where it's important to monitor for progression. Next slide. Again, next slide. Yeah, sorry. So this just shows a picture of a nerve with vasculitis. Could you go back one, please? Sorry. This is a blood vessel in the center surrounded by inflammatory cells. The blood vessels has a clot in it. So this is a typical picture of microvasculitis in peripheral nerve. Next slide. This shows a nerve with amyloid, pointed out by the arrow. It's a sort of waxy proteinaceous substance. It could result either from immunoglobulin light chains in patients with monoclonal gammopathies or lymphoproliferative disorders, or else in hereditary amyloid from transthyretin mutation. Next slide. And this shows what we call granuloma or sarcoid, with these big giant cells in the center, which are diagnostic. Again, these usually affects the lungs. They could be identified by X-ray or CT scan of the lungs, but sometimes only affect the nerves. Okay, next slide. So what to do if the neuropathy is progressive and all the tests, including nerve biopsy, are negative? Unfortunately, this doesn't commonly happen, but can happen on occasion. And there's really no consensus. It might be autoimmune. Some autoimmune conditions don't show up in tests. For example, typically we think if the neuropathy is demonic, it's autoimmune and treatable. If it's axonal and none of the tests show underlying autoimmune conditions, we consider it idiopathic. But some axonal autoimmune conditions don't show up in testing. More recently, there's, for example, with checkpoint inhibitors, which actually disinhibit autoimmunity. People develop axonal neuropathies. The only way we know they're autoimmune is because they occurred after treatment with checkpoint inhibitors. Otherwise, there'd be no test for them. So if the neuropathy is multifocal, which happens with inflammation, or rapidly progressive, some physicians would advocate treating with off-label experimental treatments such as corticosteroids, IVIG, or rituximab, but treating conditions where you're not sure what you're treating with potential side effects is a risk. So depending on risk tolerance of the patient or physician or both, the physician may or may not consider it or recommend it. This has changed over time. For example, when I used to give talks on neuropathy beginning in the 80s. So in the 1980s, where I would ask the audience if a patient had a progressive condition and no cause could be found, would you treat with steroids? And almost everybody raised their hands. In the 90s, I would ask the same question, and people in private practice would raise their hands. People in academics would not. In the 2000, 2010 range, nobody would raise their hands. So Risk tolerance has really decreased over time, or people are more cognizant of potential dangers. These are not trivial. The risk is both for the patient and a physician. An extreme example is what happened with Michael Jackson. He was treated with propofol, which helps relax and helps sleep, and he ended up dying, and his physician ended up in jail. So it's not a trivial issue. I think we need better guidelines on when to try off-label experimental conditions and otherwise progressive idiopathic neuropathies. Next slide. What about alternative treatments? Well, they're called alternative because they're unproven. Most are natural occurring, such as supplements, not proprietary, so they're not regulated. Sometimes they include chemicals which could be toxic, and there's no funding for clinical trials. However, it might be possible to use social media to get more information about their effectiveness. It would be useful to establish an online database with responses could be tabulated and compared, although it has to be done in a way that the reports are validated in some fashion. Next slide. What else could be done? Well, we have supportive therapies. So patients with weakness could be helped by physical therapy, orthotics, ACE2 ambulation. We have treatments for neuropathic pain, which in most cases are effective. The idea with those treatments, it's almost impossible to make the pain go away entirely. The idea is to get it down to a level where they're tolerable and a background. If you try to eliminate it completely, you often get into toxic doses. And again, if you have autonomic symptoms, whether it's partial hypertension or hypertension, there are medications to manage these symptoms. These don't treat the underlying disease, but they do help the symptoms. Also, people feel hopeless, but they're really not. If you're wealthy, you could directly support research through the foundation or through local medical centers. Everybody can join political action committees to advocate for research funding by the NIH. As Tip O'Neill is quoted to say, all politics are local. EU representatives' main goal is to get reelected. If you get 50 people together and visit them, they'll always be available to talk to you. It's hard to get Congress to actually mandate funding for particular programs unless it's a national emergency, but you can certainly ask them to direct the NIH to report on what they're doing for neuropathy, which will alert the NIH administrators to make sure that research is funded. Right now, research in peripheral neuropathy is way underfunded compared to other conditions, in part because of lack of information, which could be provided by such committees individually or organized through the foundation. So everybody could help. So again, it's a short presentation. That's because there isn't much known about idiopathic neuropathy. More research is needed, and I'll be glad to take any questions.
Dr. Latov, thank you so very much. We have a lot of questions that have come through. We'll try our best to answering as many as we can. So let's go ahead and get started. Lots of people are asking about diets specific for idiopathic neuropathy. Do you have any recommendations, whether it's an anti-inflammatory diet or a Mediterranean diet?
Well, again, all these are unproven. They might help. I think diet is important in general for if you're generally in good health. You'll feel better, and it'll be easier for the body to deal with the symptoms and the disease and to heal. So, and my understanding of diets is certainly if you're overweight, if you lose weight, that would be helpful. Different people might respond differently to different types of diet depending on metabolism. You could certainly experiment with those, but there isn't any one diet that's known to help everyone. But again, it'll be useful for people to share information about what works for them.
And I assume that you'll probably have a similar answer when it comes to exercise, and if there's any specific exercise program in general that you would recommend someone looking into to help the symptoms that they have from their neuropathy, or is that also kind of a trial and error?
Well, again, everybody, exercise helps you get stronger. You can get about 10% stronger regardless of your baseline. Obviously, different people start from a different baseline. And if you're just slightly weak, any exercise will do. Some things to keep in mind. First of all, it'll be useful to do exercises where you're stationary, for example, elliptical trainer or strider, as opposed to moving platform or running, because you'll be less likely to fall and hurt yourself. And the pounding, for example, when you run, can cause pain, which would limit how much you could do. So swimming or elliptical trainer are probably easiest. Two, something to keep in mind is that usually when you exercise, when you build muscles, the process involves both muscle breakdown and rebuilding. If you have neuropathy, the rebuilding part isn't as efficient. So you have to limit the exercise in some way. So one way to monitor that is if you start feeling weaker during or right after the exercise, you've probably done too much. So you could do less strenuous exercises and perhaps more frequently. But you could maintain a pace where you're not getting weaker. That should be fine. Also, if you have actual weakness, such as a foot drop or proximal weakness, it should best be done under the guide of a physical therapist, or at least periodically, because the exercises need to be tailored to the weak muscles. You would be exercising them differently than muscles which are strong, both to maximize the benefit of exercise, and two, to avoid exercises which might further damage the injured nerve or muscle. So physical therapy would be helpful. Other than those points, it's important to find something that you like to do. Otherwise, you're less likely to do it.
Yeah, 100%. And switching gears a little bit as well, there's a lot of questions about vitamin supplements. If you have any additional comments about that, lots of questions about B6. Obviously, we know that it's always advised to get tested to know what you might have a deficit in before you start adding supplements to your diet. But do you have any other comments specific to vitamins in general?
Well, traditionally, people used to take vitamins because we know vitamin deficiencies can cause various problems, B1, B6 deficiency, and B12 certainly can cause neuropathy. But those guidelines were developed prior to our ability to measure levels. And most vitamins, if you take them in excess, are not a problem. Basically, the body just rids of them, and there's no damage done. But certain vitamins, such as B6, can actually be damaging if you take too much. Now, different people have different susceptibilities to B6 toxicity depending on whether they break it down or not. Some people to take just a few milligrams of B6 and the levels should way up. Others could take larger doses. So it's important to test yourself. It's also important if you're pregnant. Often people who are pregnant are prescribed large doses of vitamins because of the additional nutritional needs of the mother and fetus. But the fetus also is, could be exposed to the toxicity of too high vitamin B6 levels. And it's been shown in experimental animals. So it's important to measure levels before taking a supplement or deciding on the dose that should be taken.
That's great advice. Thank you. Could you talk a little bit more about the difference between small fiber and large fiber neuropathy, and if there's ever an opportunity for someone to develop a different cause there?
So the way we define small fiber neuropathy is if someone comes in with symptoms of neuropathy and they get an EMG done and the EMG is normal, traditionally the physician would say, well, you don't have neuropathy. I don't know what you have. Maybe it's fibromyalgia or some other pain syndrome. Or they might say you might have a mild underlying neuropathy, which he doesn't pick up. But you can't prove or disprove the diagnosis. In the past 10 or 20 years, we've developed the ability to measure nerve fibers in the skin. And we found that some people with neuropathy symptoms where the EMG is normal, the skin biopsy showed a decrease in the number of nerve fibers, and these are small fibers in the skin, and we would cause small fiber neuropathy. Now, these small fibers could be the nerve in the skin, could be the nerve endings of small fibers in the nerves, because the nerves can have large, small, or medium-sized fibers, or could be the terminals of large fibers, which lose their myelin sheath and look like small fibers in the skin. So when you diagnose small fiber neuropathy, you might have an underlying large fiber neuropathy, which is very mild and only picked up because the skin biopsy is more sensitive, or it could be small fiber throughout the entire nerve fiber. So it's really, and the causes for small fiber neuropathy are the same as for large fiber neuropathy. So, and often all the causes that we know that can cause large fiber neuropathy can also cause small fiber neuropathy and vice versa. So it may just be that a milder form of neuropathy, which is self-limiting and doesn't progress to large fiber. Having said that, that's in about 80% of the cases. So in about 20% of the cases, there's still an underlying ongoing nerve damage, and it can progress to large fiber, including things like CIDP. So if we in our center, for example, if we diagnose small fiber neuropathy, we tell the patient there's an 80% chance that it's not going to get worse and we'll just treat the symptoms, but come back in 3 or 6 or 12 months, depending on how you feel, just to make sure it hasn't progressed to large fiber. If it has progressed to large fiber, if the exam shows that it has progressed, then we will repeat the electrical studies because there's a chance that you might identify something underlying that's treatable. So again, it's important to follow up and repeat the evaluation periodically to make sure it's not progressive.
Okay. And is there any hope for restoring nerves that have been damaged?
Well, nerves could regenerate to some extent, but it's limited. Sometimes regeneration is sufficient so that you're not left with any symptoms, although EMG might show there's still some nerve damage, because there has to be a certain level of damage before you feel it, or they may not recover or only partially recover. Right now, we don't have any medications which would hasten recovery. Exercise might help just because you release trophic factors, but again, that has a limited benefit. And but there should be some way of stimulating stem cells within the nerves to help regenerate and heal. We just don't know enough about it. Again, the only way that would change is through research.
Got it. And you know, someone asked, and it's an interesting question I've never even heard before, but surgery for patients that suffer from idiopathic neuropathy. Are you familiar with any surgery being performed to help neuropathy specifically?
Well, there are a couple of types of surgery. One, if any of the nerves are compressed, for example, at the elbow or ankle, the compression could, and if you have an underlying neuropathy, you're more susceptible to compression. For example, if you have diabetic neuropathy, it's not uncommon to develop carpal tunnel in addition, because the nerves are more susceptible to a level of compression which would not cause symptoms in somebody who doesn't have an underlying neuropathy. So relieving that compression surgically can help relieve the pain and maybe help the nerves to heal. Other than that, if there are specific nerves which are damaged, for example, if you have compression at the wrist or elbow or at the knee or ankle that's causing weakness, sometimes surgery could transpose nerves or use other nerves to innervate damaged muscles, and it could recreate connections which will allow you to be able to move that muscle. But again, it's very, very specialized. It has to be only done at certain centers with experience in those particular procedures.
And, you know, there's been a lot of questions about, you know, various tests, and you mentioned several of them earlier in the presentation, including the EMG, nerve conduction, even biopsies. Could you speak a little bit more to the frequency of how often those tests should be performed or repeated, when, why, and then, you know, how intrusive, if at all, some of these tests might be for a patient?
Well, again, at the initial presentation, we would perform all these tests. The idea is to try to find a cause. If you have a treatable cause, the sooner you identify it and treat it, the less permanent damage there will be. So it's important to test for all the possible causes. After that, it's important, if we find a cause, obviously, you would treat it, and then you follow that, see whether there is improvement or if the treatment is insufficient. So usually when we start, if we find a cause and we start treatment, we tell the patient to come back in 3 months. If it's no worse or everything is well, we tell them to come back in 6 months. After that, perhaps annually. If we can't find a cause, we again tell the patient to monitor at home. If they feel, if they get worse by any of the measures that we mentioned, you know, grip strength, walking speed, functional tests, and so on, to come back as soon as they detect worsening. Otherwise, again, come back in 3 or 6 months, or after that, if they feel weaker, for evaluation. If we repeat our tests and we see the neuropathy is progressive and we still haven't found a cause, we would then recommend a nerve or muscle biopsy for possible cause. If the nerve or muscle biopsy doesn't reveal a cause, then we just treat the symptoms. Although I must say, if we do a comprehensive evaluation, including all of the tests, and it's rare, and we don't find a cause, it's rare that the neuropathy is so progressive. In most cases, we can find a cause. If we don't find a cause, then we sit down and discuss whether to have a trial of therapy with steroids or other anti-inflammatory conditions, truly understanding the potential risks and benefits.
Okay, great. Thank you so much. Um, Lots of questions on various therapies have come through, whether it's, acupuncture, even medical marijuana, right? A few that you didn't really address, and just curious what your thoughts are on some of these therapies, even, red light therapy. But then more importantly, do any of these therapies, and obviously it's dependent on the individual, I'm assuming, but what's the likelihood that some of these therapies will help someone walk better, right? Just live their day-to-day better, right? Could you speak a little bit more about how some of these therapies are used and, what the expectations realistically should be for a patient?
Sure. So acupuncture, for example, does help relieve muscle spasm. It doesn't relieve, and muscle spasm actually is a significant occurrence in neuropathy. The nerves are irritable, they're firing off, the muscles react, they're going to spasms, they're achy, and if they're sufficiently spasmodic, it limits mobility. So if you can relieve the spasm, patients feel a lot better. Certainly exercise, physical therapy can help relieve muscle stiffness and spasm. Acupuncture does, massage. Some of the muscle stimulators do that. Light therapy increases blood flow, reduces spasm. So lots of these treatments which are being advertised are really directed at relieving the muscle reaction to the neuropathy, and they do help. But again, within boundaries, they don't actually heal the underlying nerves, but they do make people feel better.
Great, thank you. And what are your thoughts about how people can, heal their neuropathy? A lot of what this organization, the Foundation for Peripheral Neuropathy, does is offer some treatment or therapy options to kind of help curb some of those symptoms. But is there anything that anyone can do to really get into the problem, the original problem itself, which is the actual neuropathy?
Well, again, if you can find a cause, you could treat it. Otherwise, you just treat the symptoms, and certainly making sure that you test for all the possible causes, knowing what they are, and reviewing the medical records is important. Usually, if you go to a neuromuscular center, they're pretty good about comprehensive testing. Your general physician or um, uh, less specialized centers might miss some potential causes. So you should probably have a list of potential causes to test for them, and then make sure your records show that you see the results. And after that, really, lots of times, you learn all you can about neuropathy. You talk to other people, you join organizations, you read books about it. You try faith healing, diets, various exercise programs, and you're still left with symptoms. And then really, you could still do something, but it really involves helping support research, either directly or through political organizations, to find out more about how to um, develop treatments which allow nerves to regenerate and heal.
Right. And a lot of times the cause is really, to your point, what a patient should address. But for people, especially those joining today that have idiopathic neuropathy, they don't have a known cause. So how would you suggest that they broach their treatment plan for this condition and keep obviously an optimistic and positive light in it, knowing that they don't have the answers, they don't have the cause, they're extremely frustrated. But what would you say to all of our idiopathic friends on the line today?
Well, if the neuropathy is progressive and you haven't had a biopsy, then you should have one. Assuming all the other tests were done, go to neuromuscular center and for consultation and discuss it. If it's not progressive, then it's really a matter of focusing on treating the symptoms. So if you have weakness, exercising regularly, physical therapy, optimizing these, finding how you could do those comfortably, which ones to do, etc., helps. If it's neuropathic pain, it's a matter of trying various medications. You asked about medical marijuana earlier. Certainly sufficient number of patients do report that it helps them. It does help also in terms of dealing with the anxiety of chronic pain. It helps you relax and sleep better, which helps deal with symptoms. If you're tired, you're less likely to be able to deal with the frustrations of the symptoms or with the chronic pain. If you're more relaxed, you're able to deal with it better and try to think about other things and go about your work regularly. When in terms of treatment for neuropathic pain, make sure you've tried everything available. Again, you have to discuss that with your physician. Also, sometimes people start with too large a dose, in which case they have side effects and they just drop it and don't try it again. It makes more sense to escalate with a low dose because you might benefit from a lower dose than that which can cause side effects. So escalating would take care of that. Also, if you do try something low dose, too many people just give up before trying a higher dose. Escalating might help. Combinations of medications could help, where one or the other by itself may not help. The benefits are often additive. The side effects are not. So we have to keep trying and not give up. Same thing with autonomic symptoms. It's a matter of finding combinations of medications that work best for you, rather than just trying something and giving up. So really, it's a matter of optimizing the treatments for your particular symptoms.
Yeah, that makes complete sense, Dr. Latov, and thank you so much for all of your help. We have probably a couple of hundred questions that we haven't been able to address today, and for those of you that have been asking them, I'm so terribly sorry. What we can do is make sure that we file all of these questions and try to address them as best as we can over the course of the next several weeks and months on our website and various emails. And know that a lot of these answers are also up on our website. So feel free to reach out to us specifically if you have some questions that we can help point you in that direction. But at this time, we did run out of time. So again, I just want to thank you, Dr. Latov, for all of your help and support today, and for the knowledge that you shared with us. It was an amazing program. We had so many people joining and plenty more who will be watching this recording at a later date. For those that are attending right now, we hope you liked this. We will be sending out a survey shortly after this meeting ends, and we value all of your input, whether it's positive or not as positive. So please share that with us so that we can keep making sure that we're meeting the needs of everyone. And we hope that you will continue to support us, whether it's by volunteering with us or giving us a donation so that we can keep doing these types of programs. But you do know how to reach us. We are available through email, phone, and have a great website. So again, thank you so very much. I'm so thankful for everyone that joined. So thankful for you, Dr. Latov, and wish all of you the best. And I'm sure we'll be speaking very soon.
Okay, thank you for having me.
Thank you. Bye, everyone.
Bye-bye.